spend from, technically tomorrow till Tuesday there. So we
Awesome.
have a few days and we're going with a couple of friends. So yeah, it'll be fun.
That'd be great.
And what cruise line?
Norwegian,
Nice. I've not been on that one.
I'm expecting it to be pretty good. We've done one before. I know this is kind of an older ship and a smaller ship, but I think it'll be I think it'll be good. But there's no like race car track or anything like that. So
I'm
Wow.
speaking on a cruise this year on the newest ship on the water. It should be fun. A dental
oh,
thing. Yeah, it should be fun. It's an amazing ship, but I mean, it's all great. In Europe like that, you're really on the boat just to sleep.
right,
It's
exactly.
like they kind of pop you around. There's maybe one day at sea, right? There's not a lot.
Right. We pretty much wake up and you can get off at, 7 in the morning and then you get on like at sometimes like 8 or even 10 o'clock at night. Like you kind of have the whole day. So
I love that because then
yeah.
you eat dinner off the boat, which is nice because
Yeah,
more authentic food and
exactly.
yeah.
Oh, it's great to see everybody. Good morning, good morning. We haven't done a master class in a couple months. We kind of took some time off from the summer, so it's great to see everybody. Hey, Dr. Mooring. All right. Well, I have two after the hour, so let's get rocking and rolling. I'm going to read your introduction, Dr. Maples, and then I will turn it over to you and I'll allow you to screen share and all that kind of stuff. 1 second here. I'm gonna make you a co-host too. There we go. Okay. All right, everybody. So Dr. Susan Maples leads a successful insurance independent total health dental practice in Holt, Michigan. She brings preventative and restorative dental expertise, a passion for mouth body total health, a master's degree in business marketing, and 35 plus years of experience in private practice. Susan is a past president of the American Academy for Oral and Systemic Health and was named one of the top 25 women in dentistry and one of the top 8 innovators, otherwise known as disruptors, in dentistry. She's the author of Blabbermouth 77 Secrets Only Your Mouth Can Tell You to Live a Healthier, Happier, Sexier Life, and recently published a book titled Brave Parent Raising Healthy, Happy Kids Against All Odds in Today's World. She's the developer of the Hands-On Learning Lab Kit, an interactional science-based learning program for dental patients, and selfscreen.net, an educational screening tool for patients and clinicians to uncover signs of illness such as prediabetes, diabetes, obstructive sleep airway disorders, acid reflux, and chronic systemic inflammation. Susan was also a co-investigator in an award-winning diabetes research study entitled Diabetes Detection in the Dental Office. She's also the creator of Total Health Academy, a robust online learning curriculum for dental teams to develop a complete oral systemic dental practice. Please help me welcome Dr. Susan Maples. Yay, good morning. Thanks.
Thank you. Thank you. I love that. Thanks, Angela. I'm going to go ahead and share and see if we can get going here. Mm. And
Yep,
play. And we're there, right?
we are there. Looks great.
Continue to share. All right. Well, thank you for having me. I'm happy to be here. I recognize some of you. I love my nerdy friends who study on Fridays, and I hope that you'll generate a bunch of questions. We're leaving 30 minutes for questions at the end. So yeah, and I love that this is interactional. I'm excited to begin. For those of you who haven't heard me speak before, I grew up in a household that was super funny. In fact, I'll tell you a little story. I grew up partly with my grandma Kitty. My grandma's name was Harriet, but my grandpa didn't like the name Harriet, so he called her Kitten, and everyone called her Kitty by the time I was born. By the time my brother was 2, he couldn't pronounce Grandma Kitty, So he called her Damatity, and she loved the name Damatity. And she was quite well endowed and proud of that. So, this was like the family that I grew up in, a grandma whose denture would fly out when she laughed too loud, or she'd pee her pants, whichever came first. So a little naughtiness, a little humor, and still have it. My grandma, my Damatity, was also very wise. She had two poems on her refrigerator that we have on our refrigerator, and that all of our children, in fact, my patients, we give them out, have been asked to memorize. And one of them says this: "You're sure you're right? How fine and strong, but were you ever just as sure and wrong?" My grandma Kitty made sure we memorized that because, we want to be quick to apologize and quick to recognize that other people have answers we don't. I'm here to learn from my patients. I'm here to learn from you. If anything, I'm a continual student. And also, in 40 years of practice, I've been wrong about a lot. In fact, some of what I tell you today will be wrong, and yet it's evidence-based, so we're looking for new evidence to prove us wrong. And when we get that evidence, it's important for us to be conscientious about it and to share it, and then to be able to say, I wish I knew then what I knew now. So, with all humility and humbleness, I want to kind of continue to, now all of a sudden, it's always something. Let's see, why is it not advancing? There. Yeah, now it's going. So there's the poem in case you wanted it. And yes, I've been busy creating tools to help people be successful in all things oral and systemic. To me, the oral systemic link was all about perio and bacteria. And it's so much more than that, as many of you know. But today we're going to look at two particular areas: diabetes and acid reflux in the dental office, with a lens on periodontal disease. But we're also going to look at the lens on all kinds of lifestyle related stuff, including how does this impact HPV risk, HPV, oropharyngeal cancer risk, et cetera. So there'll be a lot of kind of, again, intersecting pieces. Recognizing that the mouth is complicated, right? That oral disease can impact the body in very significant, dangerous ways, and oral health can impact positively, but also the telltale signs of what we see going on in the rest of the body manifest themselves in the mouth. And once you see it, you don't get to unsee it. So today, I hope, hopefully for some people will be like, oh, that's what that is. Cool. I chose acid reflux and type 2 diabetes to team together because they're both so common and raging through people's mouths, and in ways that we don't, as dentists, recognize. We look at tooth structure. Most dentists are looking for, what do I need to restore, which is treating the ramifications of the fire rather than what is causing it. I always think of this as, if you were to drive up to your home right now and your home was engulfed in flames, most of us um, would call 911 and get the fire out. We don't call a carpenter to put the fire out. I'm sorry, to fix the roof while the fire is still licking away at the floorboards, right? We put the fire out, we look for the root cause, we fix the cause of the fire before we do a restorative plan. And in dentistry, that really isn't the way. We show up after the hygienist has cleaned off the teeth, and we're sort of looking for what needs to happen to restore the teeth. The conversation about how did this happen and what's the root cause and how do we mitigate that ongoing damage before we develop a restorative plan, or at least in conjunction with a restorative plan. It's a different conversation. And it's very complicated, considering that human beings are complicated. Our habits are complicated. Our food system, our food supply is a mess. The things that we're drinking are acidic. There is a reason that type 2 diabetes and acid reflux are both so prevalent in today's world. And so much of it's undiagnosed, and we are in a position to see it. And we need to address what those reasons are as well. So it's estimated today that 80% of our US healthcare costs are from chronic preventable disease. If you believe that we have a healthcare crisis right now, which most people believe, I want to say that if 80% is preventable, we wouldn't even have a healthcare crisis if we could focus on prevention. But of all the dollars we spend in healthcare, only $1 from every 100 is in prevention. I'm not talking about early detection like colonoscopy and PSA tests and mammography. I'm talking about truly prevention. We don't get paid for it. And yet, dentistry is the last bastion of prevention left on the planet. People schedule 6-month preventive visits regularly. They show up in your office regularly, presumably well, to get their teeth cleaned because they believe that cleaning your teeth helps their overall health. The truth is, cleaning their teeth every 6 months does not render evidence of health. Let me say that again. For people who show up every 6 months to get their teeth cleaned, they may be more conscientious in general and maybe a healthier lot of people, but the act of cleaning their teeth is not what is creating health for them. It is, however, bringing them to the office, and the office, that office preventive visit where the hygienist has a full hour to engage with a patient, presumably well, to help them kind of hold the container for what else is going on in the rest of their body, is in many ways the next big push in medicine. So when you look at what's happened to nurse practitioners and physician's assistants and the roles that they're taking, I believe that hygienists have even a higher calling given that we've been in prevention for a long time. So, toxic pills and surgery and restorative dentistry are the solutions that we often offer people for disease instead of lifestyle change coaching. And that ability to help people coach, to coach people through a healthcare change or a lifestyle change is not an easy thing to do. The patient needs to be somewhat open. Every single one of us wants to be healthier, but making those changes, as you know, is difficult, and we're in it with them. So I love this analogy. Which would you choose, sick care or health care? None of us on this call associate more medications with better health. And yet, our refrigerators often don't look like a garden of vegetables where we're getting phytonutrients or medicine through food, right? So, how is it that we help influence people to eat well, hydrate well, sleep well, not just in terms of quantity, but quality of sleep, and manage their stress well? Those are all, the psychosocial, spiritual elements of health are all prevalent in today's world where we're suffering 40% from anxiety. Um, so all of this is super important if we want to truly be healthcare professionals in the dental world. This is all bad news in terms of trends because the trend is for us to get sicker and sicker. We are managing now our obesity, metabolic disease rates with injectable medications, and we'll talk a little bit more about that as we move through this. But even that will have its negative parts. And so again, that's not root cause oriented. That truly is fixing the roof while the fire is still licking away at the floorboards. That's all bad news. The good news is we are literally the ones we've been waiting for in this healthcare crisis. And if we can procure our spot to make that preventive visit meaningful for the patient, we will become one of the most important aspects of healthcare. If we are not successful in making that 6-month preventive visit count, the insurance companies will nix it. Actually, we will all nix it because when there's a healthcare shortage, if the cost of healthcare gets to be so astronomical that people want to cut here and there, they will cut something that they perceive doesn't matter, and insurance benefits will cut that. The insurance companies recognize that people that show up for preventive visits in healthcare are no healthier than the rest. That data has been out there for a long time. In fact, in Canada, they're not even paying for well visits anymore. Most people show up to a physician's office with a problem-focused examination, and it's a quick in and out. The average time people spend with a physician right now um, is 7 minutes face to face with a 15-minute visit. That includes the electronic medical records and a break for them to get from one room to the next. So we are, again, the ones we've been waiting for. This 6-month preventive visit came from this advertisement. It came from Pepsodent, an advertisement way before we were looking at evidence-based recommendations. It basically said, if you want to have strong, healthy teeth, do these 3 things. Eat correctly, see your dentist twice a year, and use Pepsodent twice a day. These are the 3 rules to follow if you seek lovely, healthy teeth. Well, I'm here to tell you that 2 out of the 3 of these we still recommend today, even though we don't have evidence to suggest that this makes you healthier. Brushing your teeth twice a day and seeing your dentist twice a year. We do have plenty of evidence that eating correctly will help with a healthy, everything from a healthy microbiome to healthy teeth. And yet that's the one piece that we sort of haven't kept from this advertisement. We've sort of left that out. Right now, in today's world, we deal with these 4 diseases primarily. Caries disease, which is increasing, periodontal disease, which is increasing, oral pharyngeal cancer, which is hugely increasing, and occlusal disease, the wear and tear of bruxism. And we notice that none of these are getting better on our watch, just as the human condition in all kinds of other areas is not getting healthier. Now, people who hang out in circles of educated people will have a sense that all of these diseases are getting better. But in fact, if you look at population statistics, they really aren't. 20% of 2-year-olds get caries disease, a third of all 3-year-olds. This is a preventable disease, 100% preventable. We look at, I digress. Let me keep going. So in terms of acid reflux, 60% of US adults report some reflux and 20 to 30% report at least weekly. That is huge. Why is the acid that is designed to kill bacteria, bugs that don't belong in the GI system? It sits in your stomach and it's there to protect you. Why is it going up instead of down? Why is it the GI system has reversed itself and the acid comes up into your throat, into your mouth, into your sinus cavities, and wreaks havoc with everything from the microbiome to the pH that the teeth, to protective pH that the teeth live in, to increased mucus production, to throat clearing, to nasal congestion, all of that. Why is that happening and how can we fix that? So we're going to look at that. It's so common that I love this. I know that lasagna gives you heartburn, so I mix some Tums into it. Instead of pepperoni on the top of the lasagna, it's Tums. And so let's take a look at our anatomy. Oral pharyngeal cancers occur where the oral cavity and the pharynx merged. I pulled this from an HPV talk, HPV oral pharyngeal cancer. That's the oral pharynx where the green is. Below that, you get the hypopharynx, which is the purple. And then above that, you get the nasopharynx, which is the yellow. When we get acid above the esophagus, we no longer call it GERD. GERD is gastrointestinal, or esophageal reflux. We no longer call it GERD. We call this airway reflux. It is literally up in what we consider the airway. And so that's our anatomy lesson. We're going to talk about airway reflux and how it impacts the oral cavity right now. So a lot of people who experience heartburn, literally it's in the esophagus. And I want you to imagine what a canker sore feels like if you've had one, or any oral ulcer. It's painful. So when you get ulceration of the mucosal tissue and you're into that very sensitive nerve layer of the mucosa, it is painful. And the acid continually burning on that tissue can be quite painful. When people have what we call silent reflux, where they don't get that pain, then we start to look at what is happening there with a little drop of saliva entering up past the esophagus. Now, if we look at the role of reflux in laryngeal and esophageal carcinogenesis, in other words, cancer, I want you to also recognize that acid reflux 5% of the time becomes Barrett's esophagus, esophageal changes that are precancerous, and then esophageal cancer. We've all heard of this. We also know that in terms of oral pharyngeal cancer, where it's above the esophagus, we know that acid plays a part in promoting HPV persistent infection into smoking, as well as the acidic diet. So we're not just talking now about the acid produced by the stomach coming up, but the acid you're taking in. In 1973, the FDA, we had a botulism outbreak in the United States that caused the FDA to change their regulations on liquids in the grocery store. In order to keep the bacteria out, we added acid to everything wet. Anything that has a shelf life is acidic, and so you will recognize even most bottled waters are more acidic than tap water. We're going to talk a little bit more about that. We not only want to pay attention to the acid coming up, but the acid going down. The silent factors of airway reflux look like this. They may not be associated with pain in the esophagus, heartburn, but they would have enamel erosion, where we're starting to lose enamel at a pH of 5.5, lose dentin at a pH of 6.5. We'll talk more about pH in a bit. And active caries. So when you have bacteria that eat sugar and produce acid, the acid environment that the tooth lives in is going to promote active caries. The hoarse voice, the postnasal drip, the throat clearing, the chronic cough, the lump in the throat, indigestion, burping, bloating, and nausea. These are all symptoms of silent reflux. Silent reflux was really coined by Jamie Kaufman, an ENT, who is the founder of the Voice Institute of New York, who wrote the book Dropping Acid, and she's done a lot in this area. But we have to recognize those patients that are in our chair that can't be set back in the chair because it feels like they're going to choke, or they're constantly, or the ones that are saying, I need to hold the saliva ejector. You know these people, right? You know these people, the postnasal drip, the throat clearing, the constant throat clearing. They're the people that we find irritating to work on. But think about the fact that this reflux reaction, the overproduction of mucus in response to that acid, is there with them all the time. You want to talk about irritating. It's irritating to them 100-fold more than you. The effects of acidosis in the mouth are huge. They're also huge in the rest of the body. We will talk a little bit about acidosis in the body if we get time. Enamel erosion, caries disease, again, activation. And then we look at fungal infections. When we start to decrease saliva or increase acid, we change the microbiome in the mouth, and we start to allow overgrowth of fungal infections. Chronic gingival inflammation. So when we see inflammation, we often, as dentists and hygienists, think of this as a plaque issue. But I'm here to tell you that we get inflammation from food sensitivities, from nutrient deficiencies, from acid, from all kinds of different ways. And we have to recognize that the pattern of inflammation looks somewhat different from the inflammation we see from plaque at the gingival border, at the gum line. So, and then periodontal disease, the promotion of bacteria that cause this. Now I want to jump over and give you an introduction to diabetes. I'm going to go back and forth on these a little bit today. I hope that's not too irritating to you. For those of you who are ADHD, you'll probably love it. Oh, a new subject. Here we go. So when I look at this mouth, I see some what you might call red bleeding gums. They're not bleeding in this. This is almost a caries-free mouth. And you can see on the mesiobuccal of number 11, there's a little bit of exudate. You can see also deep wells maybe of inflammation behind the incisors. And when I look at the radiograph of these teeth, this is a young person, by the way. I look at this as very significant and advanced periodontal disease, and it really is diabetes. And we're going to talk about what that means. We often recognize diabetes as, whoop, I've got a window that popped up here. Maybe, not sure how to get rid of it. It says Kirk Behrendt, external add contact. Anybody know how to get rid of that? I can't do, oh, it's in the middle of my screen. I'd love to get rid of it, but I guess I can advance. I'll keep going. If
Is
you
it letting you just X out of it or?
No, I don't have a, let me escape for a second and see.
Sure.
Get rid of that. Okay. I did that. Now how to get back to my slides. Am I still sharing?
No.
Okay, let me share again. Zoom is wonderful when it works, isn't it? Okay. I'm right here. And play. Okay. Good?
Yeah, looks great to us.
So with diabetes, we have 78% of our diabetics are considered undiagnosed, and they're walking in your office every day. There are, of the 22% who are diagnosed, there's a large number of them who are really not controlled. Both the uncontrolled diabetic and the undiagnosed, I'm sorry, I got that the other way around. 78% are diagnosed, 22% are not diagnosed. But of the 78%, there's a large percentage who are also uncontrolled. So even uncontrolled hyperglycemia and hyperinsulinemia and undiagnosed diabetes are going to significantly impact gum health and bone health in your patients. And right now in the world, this is 2017, I would suggest that this number is even higher, 8.7 million undiagnosed. Now, let me also tell you that in 2012, we had 16 million diabetics, and today we have 38.4 million. Diabetes rate has grown so incredibly fast and high that we are projecting, based on our insulin resistance in today's world. By the way, insulin resistance we've heard a lot about. This is the precursor to diabetes, and insulin resistance by 2050 will have promoted diabetes to a rate of 1 in 3. So when you think about this, my son graduated high school in 2012. That's the year I did the diabetes research project. We had 16 million diabetics, and I was floored by that number. Now today, with 38.4 million and expecting 1 in 3, which would be, again, 33% by 2050, it's unbelievable. So I'm super concerned about that. Right now, we report in 2024 that 46.5% of our population is diabetic. And all told, between pre-diabetes and diabetes, we have 136 million US citizens diabetic. Why are these numbers important? Well, because they wander in your office and they don't know it. And it has a bidirectional relationship with periodontal disease. Each makes the other worse. We're going to talk a little bit more about that. Insulin resistance is gaining a lot of clout right now in the metabolic world. We may be learning that hyperinsulinemia in the patient whose body doesn't recognize circulating insulin is maybe more dangerous to the body than hyperglycemia. And so we have we're burning out the beta cells in our pancreas and rendering our pancreas unusable. And that creates, of course, all kinds of vascular risk in terms of every aspect of the body and certainly of the mouth. So we're going to talk a little bit more about it, but the obesity rate in our country continues to increase. We are managing obesity again through the series of peptides you've been seeing released that literally help people by providing the satiation hormones that our bodies are no longer producing. We have muted our ability to tell when we're hungry or not, and we're flat out overeating. And when you look at the impact of sugar on, on hunger hormones from leptin to ghrelin, you know that manufacturers have put sugar in everything we eat in order to increase our hunger. And now we're trying to quell that hunger by injecting something that will unfortunately reduce our endogenous hormones, GLP-1, PPY, CK, what are the hunger hormones? But anyway, I'm here to tell you that the reason that these backfire is because when I say backfire, you really do need to be on them forever, because the they will absolutely suppress the hormones. The appetite suppressing hormones will be depleted, CCK, GLP-1, and PPY. And so what happens when people go off of them is they get a raging hunger and they eat their way back to obesity. And that is because we've never really solved the problem, which is not portion control. It's that the food supply itself is a mess. How do we use food to create satiation? And how do we pay attention to our satiation? That would mean returning to real food. That would mean addressing our number one nutrient deficiency, which is fiber. And we're going to go back to talking about that because, again, it is in my mind, it is our privilege to be able to help people understand the root cause rather than just relying on a pharmacological solution. So this is real. These ads, this is what in my mom's day, my mom died 10 years ago today. She would have been, when she died, she was 82, so she would be 92, but this is in her day. Men wouldn't look at me when I was skinny, but since I gained 10 pounds, this new easy way, I have all the dates I want. Now there's no need to be skinny and friendless. Even if you could never gain an ounce before, here's a new easy treatment that's giving thousands attractive flesh in just a few weeks. What do you think happened between my mom's generation and today's generation that causes no one to wonder how they could possibly gain weight on their skinny little bodies, right? We have a major food shift in our culture. This is the cover of JADA in November 2010. How many dentists would be interested in addressing obesity in patients? You would be surprised. 50% said they would like to address this, but only 2.6% were doing anything regarding diet at all. And what we do know is that exercise makes a big difference as well, but we can't out exercise a bad diet. So when you go back to that Pepsodent commercial, talking about eating good food is part of what we're supposed to do. I believe that in my heart of hearts, taking the time to talk to people about their struggles with not only relationships to food, but food itself. That requires that we have to learn a little bit about that. And we live in that world of food because we eat food too. So it's always interesting to learn more and to help people sort out where they're struggling. What's the primary cause of the obesity epidemic? It really is sugar. We saw sugar. What originally, when God put sugar on the planet, he put it in the plant that had the fiber already in it. That fiber is considered the antidote to the sugar. The fructose that's in the fruit was never supposed to be consumed without its antidote. So we extracted sugar from things like fruit and from beets and from sugar cane and from more recently corn, and we threw the plant away. We took the sugar out, we sprinkled it into everything we eat. The only source of pure sugar um, before we started commercializing food was in honey. And the bees that lived in the honeycomb were pretty good living proof that we were not supposed to tamper with the honeycomb and eat the sugar directly. But when you eat it with the fiber is so interesting. It is literally our number one nutrient deficiency on any nutrient deficiency list. You will see fiber above vitamin D, above calcium, above protein, fiber, fiber, fiber. And here's why. Fiber goes in the mouth and it stays all the way in the tube. It stays in the digestive system all the way through the stomach and the large intestine, duodenum, the small intestine, comes out the poop chute, never leaves the tube. You can think of it like straw or hay, that once it becomes wet, it literally becomes a gelatinous, gooey mess, and it moves very slowly. And you've seen living proof of this if you've ever put chia seed or ground flaxseed or any of these high fiber components in your smoothie and left them on the counter. Within 10 to 15 minutes, that becomes almost like a pudding. It's not pourable. And that is the impact of fiber. This thick gelatinous mess moves through the gut very slowly, allows the sugar in the plant to eke out slowly, allowing our pancreas, the beta cells in the Isle of Langerhans, to produce insulin in response to these very little injections of sugar throughout the digestion of that. It moves so slowly through the gut that it keeps us satisfied for a long time. High fiber foods are filling and keep us satisfied, and our hunger hormones respond so well to that. In fact, so much of the sugar is contained in the gelatinous mess that it moves all the way through to the to feed good gut bacteria in the duodenum, and it's what we call prebiotics. It promotes good gut bacteria, especially if we have a large diversity of gut bugs, which is what we consider where we consider the center of our autoimmune system. So when we look at fiber, this is really critical to understand. And without it, you get a bolus of sugar hitting the GI, hitting the blood sugar, hitting the blood right away. And what happens when you have too much circulating sugar? You get a huge rush of sugar. Let's say we drink some orange soda, or we drink some Gatorade, or we drink, or we have a piece of candy. You get a high sugar rush, and then the pancreas will spit out a huge burst of insulin to try to, you don't excrete this through your kidneys and pee it out, right? Sugar either gets used or stored. Every cell in your body needs a little tiny bit of sugar. If you're running a marathon, you need more. If you're sitting here watching this webinar, you need less. And what happens is that our body produces insulin, who comes out. It's like a workhorse. It hangs on to the glucose and drags it into the cells where you need it. Where you don't need it, it's stored as fat. And it's not just stored as subcutaneous fat, the fat that we don't like when we look in the mirror, but it's stored as organ fat also, which is a huge contributor to everything from cardiovascular disease, strokes, heart attacks, etc. Fatty liver disease. I don't know if you're aware that non-alcoholic fatty liver disease is impacting 55% of our overweight children, 26% of all of our children. And this is something that we haven't really been in the habit of measuring, like ALT levels in children, So now we unfortunately fail to recognize it until these kids get really sick. So a lot of that comes from the fact that we have um, overloaded the body with fructose. When we switch to high fructose corn syrup, we have 2 molecules of fructose per every molecule of fructose that we had in table sugar. So that's only processed through the liver, and that's really hurt the liver. So when we look at the obesity rates in youth or in all of us over time in the US, it has really mimicked the sugar consumption from, again, look at it in the 1800s and then what's happened just in the last couple hundred years. Now, I'm going to tell you that if you accept that the human race is 100 to 200,000 years old, 200 years is the blink of an eye. My own grandfather was born in 1890. I know he was an older grandpa, and I'm 65. So, but in my mind, it's like 1890 isn't that long ago. We tend to think of it as a long time ago, the olden days. But look back at what happened in the 1800s to 1900s as we started with agricultural societies, and then we take a look at what's happened since we've commercialized our food supply. So it's a real concern. In terms of liquid sugars, half of our calories come from liquid sugars. Look at the gallons of soda per year increasing from 1950 with the percent of adults with diabetes on the almost exact same curve. So that's a real problem. White flour is the same way, same with white rice. Anytime you take a whole grain and knock the hard fiber component off and grind it into flour and eat it, it dumps into the system just like sugar does. So I don't care what flour it is, whether it's wheat flour or oat flour or rice flour or whatever it is you want, gluten-free versions, they all go to sugar. So it's it's okay to eat sugar and flour sometimes. Our body can respond to a jolt like this. I say to people, you can visit there. This is flour and sugar, but you can't live there, because if you live there, you get yourself into a heap of trouble. So if you're waking up every morning to, coffee with coffee creamer and a blueberry muffin, that's living there. That's an issue. The sugar consumption in our country, the World Health Organization asked us to reduce our sugar consumption by 75% for the health of our country. 75%. They agree with the American Heart Association, who says 5% of our consumption should be sugar. And if 5% of a normal 2,000 calorie a day diet would be about 100 calories or 26 grams or 2/3 a can of a cola for the whole day, the whole day. So that is a real issue for us, is the overconsumption of sugar that's caused not only fat storage and obesity, but metabolic challenges, and the diabetes rate is out of control. So now we're going to take a look at, we're going to change subjects a little bit again and take a look at the impact of both of these on periodontal disease. And I will share with you that periodontal disease is not a calculus disease. It's not a scraping disease. It's a bacterial infection, and every single person has a different response to these bacteria. So it's what we call host modulated. So when we look at the host response to this bacterial challenge, this predicts whether or not we're going to have significant periodontitis or not. So when we, as clinicians, are diagnosing periodontal disease, usually we diagnose it by by putting a probe in a sulcus and looking for what? Measurable bone loss and bleeding. This is advanced disease. If you already have catabolism of bone, you've lost bone, you can see it in the radiographs, you can see it in the mouth, you can see it in the probing depths, you have disease that was not diagnosed. So we are, in effect, scraping teeth on, we're trying to, like, again, patch the roof, not prevent the disease. So we're not talking about prevention when we're talking about treatment, right? But how do we prevent the disease? I want you to keep one eye on prevention as we look at how we treat the disease in today's world. We need to look first at the bacteria. What bacteria live in this person's mouth? Now, the mouth is a home to about 900 strains of bacteria. Again, um, it's you're sure you're right how fine and strong, but were you ever just as sure and wrong? I'm positive I'm wrong about how many strains are in the mouth. We just don't know how many. But right now we're counting about 900 strains of bacteria, and every person's bacterial mix and load are unique to you, like a thumbprint. If you're lucky enough to be kissing your spouse and you're doing bacteria testing, you're going to notice that the spouses of your patients are an almost identical thumbprint to you, as well as moms, caregivers passing on, for instance, carcinogenic bacteria to babies. Whole other subject. But when you look at like, well, if a husband and wife or two partners are swapping spit and their bacterial profile looks similar, why is one demonstrating more advanced disease than the other? And that would come down to host immune and inflammatory response. I always say we are fighting a bacterial challenge. We need to know what bugs are present because we've identified the most significant bugs, the most dangerous bugs, not only to catabolism of bone and inflammation in the mouth, but where they creep into other organs and wreak havoc, creating blood clots that cause heart attacks and stroke. Again, exacerbating diabetes risk, all of that. So we want to look at the bacteria and we want to look carefully at who is this person and what is their status. What's their level of health and disease, and what aspects of that are going to impact our progress in solving this disease? The American Academy of Periodontics suggests that we really can't cure this disease. We can only babysit it while we can address it and watch it go down. I call this the peri-go-round. Here we go round the peri-go-round, the peri-go-round, the peri-go-round. Here we go round the peri-go-round again and again and again. And hygienists, you might be going like this because you're scraping teeth and you're asking people to brush and floss and you're giving them some microbial rinses and maybe you're using some laser therapy. And then 6 months, a year, 2 years, you're wondering when is it appropriate for me to recommend that we do this again? And to me, it's a little bit of a lesson in insanity, right? Repeat the same thing and expect different results. But after we mix the bacterial challenge with the host immune inflammatory response and all the things that go into that, we get connective tissue and bone destruction. And then we put a probe and say, oh, here's a 4 millimeter bleeding pocket. You better floss a little bit better. You're starting to get some pockets. Instead of saying like, what do we need to do? Let's look at the bacteria. Let's look at the host immune response. Let's coach the person. Let's treat the disease. We also want to look at genetics, which is a small percentage of this, about 5%. That's usually early onset, parents who have lost teeth, severe disease in younger people, etc. But we can test for that in saliva as well. And by the way, the genetic testing for that is very similar to the genetic predisposition to cardiovascular disease. And so we can share those results with their physician as well. We're not talking too much about cardiovascular disease today, however. We have a whole host of environmentally acquired factors, such as smoking. We know that patients who smoke, regardless of whether they're meticulous with their oral hygiene, are going to lose bone. We don't quite understand the physiologic process of that, but we do know that it is real. And when you, as a hygienist, have recommended periotherapy for the smoker who's meticulous about their oral hygiene and there's nothing to scale and you're scaling teeth on a smoker because they're losing bone, you might as well give up and go home. Or better yet, put the chair up and listen to the patient talk about their frustrations and their history with quitting smoking and what they've thought about, what they've tried, what's been successful, where they've stumbled, What else is possible? I always say if you're not practicing smoking cessation with a perio patient, you're not treating perio. So we need to be better at that. But what about diabetes? Diabetes is a bidirectional relationship. What does that mean? Anyone who's this uncontrolled or undiagnosed diabetic who has hyperglycemia is going to have an increased risk of bone loss and inflammation in the gums, regardless of the plaque. It is a diabetes promotes the bacteria, the bad bacteria, to cause catabolism of bone. Vice versa, also, the infection that you are dealing with in the mouth is going to make it almost impossible for them to get glycemic control. This is what we call a bidirectional relationship, and I'm going to talk a little bit more about that. There are other aspects I'm not going into with the periodontal uh, uh, conundrum here, like sleep, which is a huge factor, like hydration, like depression, periods of time where they're not caring for their teeth as well or their bodies. There are lots of other systemic factors. And when we do periodontal treatment therapy in our office, we bundle it together. So we diagnose how severe is this in terms of how many and how significant are the oral factors and the systemic factors. And we set one fee, as you might do if you are an advanced restorative dentist and you decide to restore or do any kind of a full mouth reconstruction, whether it's prosthetics or implant-borne prosthetics or full mouth ceramics or whatever. You're coming up with a fee and you're going to create a solution. And with our perio, we do the same thing, and then we give the hygienist carte blanche on the time that they need to invest in that. And that includes giving them every tool they need to be successful and helping them build skills and behaviors and beliefs, habits and beliefs about what they need to do their part before you would ever touch the tooth with a sharp instrument. So that's a whole other thing. But these are the 5 bugs that we consider the most significant: AA, PG, TD, TF, and FN in doing a saliva sample. These are the bugs that end up circulating through the bloodstream and ending up in places you don't want, including the brains of Alzheimer's patients and the clots of heart attack patients and stroke patients. And they are also hard at work to catabolize bone, to cause the gums to unzip and the bone to melt away. So we know that these oral pathogens are also neurotropic, meaning that they live in nerve ganglia and they're modal. So we see them in the brains of Alzheimer's patients, and they are not 100% causative of Alzheimer's dementia, but Alzheimer's, like periodontal disease and like cardiovascular disease, is multifaceted in its root cause, and we definitely recognize that some of the oral pathogens, including herpes simplex 1 and um, um, PG and FN, are present in the brains of Alzheimer's patients, and also Candida. So we again we don't believe that the mouth, well, I'm sure none of you believe that the mouth is isolated the way we were taught in dental, at least the way I was taught in dental school. So when we look at the other aspect of this, not just circulating bugs through the body, but the chronic inflammation that occurs at the gingival border is an issue. If you took a circumferential measurement around each tooth and added up all of that surrounding gingiva, it would literally be from the tip of your finger to the top of your shoulder. If someone were walking around with a chronically inflamed open wound on their tip of their finger all the way up their shoulder, you would get help for that. Unfortunately, this level of chronic inflammation doesn't doesn't hurt, and so people don't often go for help with this. And yet we're the ones to help recognize that this is chronic inflammation. So when we look at what does chronic inflammation do in the body, I always want to say, is inflammation good or bad? Acute inflammation is good. Without it, we would die. It's our body's response to bacteria entering the body. So it's the redness and the puffiness around a cut or a sliver. And when we deal with that, it goes away. Unfortunately, in the mouth, it is a chronic inflammation. And this is really the impact of how we get acute inflammation, anything from trauma to allergic reactions and frostbite. And then if it becomes chronic, it really plays out in all kinds of autoimmune problems like lupus and fibromyalgia, but also, cardiovascular disease, which is, by the way, our number one disease, neurologic disease, all that, and chronic fatigue syndrome, et cetera. So we have a major role in helping look at how to reduce chronic inflammation by treating periodontal disease. When people come in with an inflammatory panel from their functional or integrative medicine doc, and they are looking at high levels of tumor necrosis factor alpha, or interleukin 1, interleukin 6, C-reactive protein, we know that we have a part in that. And it is only the dentist and the hygienist who can help diagnose that, because again, doctors don't know what they're looking at. Physicians generally don't get any level of oral health education in school, and we have a responsibility to help the patient recognize it, because they often don't feel it either.
It's a video of a white blood cell going after a parasite.
This is what it looks like inside of inflamed tissue. This is a
Taking that thing down, isn't it? Look at it.
A macrophage going after bacteria bug, and all of the red blood cells that make the tissue red, and all of the interstitial water or edema that causes the puffiness. So people don't really understand what is going on here. Red, puffy, bleeding gums, if you see them as a hygienist, like this, where it looks sort of minor and we're telling people, oh, you really could be flossing. This is active infection, and we have a responsibility to help. We ask people to spit in a cup. We look at 11 pathogens in our office, and we look at the 4 in the first column there, AAPG, TF, and TD, and then also FN, which is the second, as the most significant. But if they're over threshold, we're looking not just at the presence of bugs, but we're looking at the bacterial load. And this will help us determine whether we need the patient on antibiotics during the scaling and root planing. And when I say that, this is not just about antibioticing and scraping. This is when we get to that, we want them covered. And I want you to consider the fact that if a patient has hyperglycemia and they are dealing with these bugs, they're even more at risk. And so we definitely do not want to be releasing these bugs through the body of a patient who's diabetic, because we can see that exacerbate other infections in their body as well. We've long known this for our unstable diabetics. We want them medicated, pre-medicated with antibiotics. But now we know that we can be specific with the antibiotics because we do culture sensitivity testing. These, by the way, this report will absolutely recommend which antibiotics. You can see down below there, it says amoxicillin 500 milligrams BID for 8 to 10 days, and metronidazole 500 milligrams 8 to 10 for, and these are pretty hefty antibiotics together. And so they will help us, but we also know that we are destroying some gut bacteria, and we want to be able to prescribe to dispense the really high quality probiotics with instructions on how to take them, and also advise no alcohol with the metronidazole, et cetera. So this is not a simple thing. We are literally physicians of this masticatory system, to quote Pete Dawson. We are no longer thinking that a sharp instrument and a piece of string and good brushing solve this disease. But we have always touted scaling and root planing. Why? Because that's where we get paid, and that's still where we get paid. We don't get paid to have these ongoing conversations. And I can tell you that if you are practicing within the guidelines of what your insurances, what the patient's insurances allow, and you're bound by those contracts to cap your fees at that, you are going to have a very difficult time treating this disease in any way other than scraping teeth. So again, when I set a fee, let's say the fee is, you know, $3,500 or $4,500 for the perio package, and it represents a number of visits, and we're addressing each one of these factors I'm talking about. And the scaling and root planning is the only thing that the insurance allows. A small portion of that will be paid for. So it means that patients need to literally accept that this disease needs help, that their insurance isn't going to pay for that much of it, and that they need to participate. And I think you get a patient who's much more responsive and responsible for wanting to treat this one time in their life, one more time. When I love this, it's difficult to get a man to understand something when his salary depends on his not understanding it. If you're bound by insurances, and this may be one of the questions that comes up in the chat later when we have our Q&A, is like, how do we move away from that? I don't know if you remember in 2016 where all our patients were told they didn't need to floss their teeth anymore. This is pretty funny. I'll let you look.
Hi, Steve. So I don't know if you've seen this in the news, but recent studies show that flossing has no benefits whatsoever.
Flossing doesn't?
Flossing.
Really?
So I've been flossing all my life, and I feel like I've done it for no reason at all. Steve, you have perfect teeth. Do you floss? If so, is that the reason why your teeth are so perfect now?
I don't know, but I tell you one thing, I'm not finna stop flossing. I don't know what survey they did, but I done seen some stuff on that damn string that I didn't know. I know good and hell well if it had stayed up in there any longer. I know good and hell well. Flossing, there's got to be a benefit to flossing. Who came up with this study? That's stupid. That don't make no sense. If you don't floss, decay, stuff sits up in them cracks. And I'm telling you, man, you could develop this thing called Zachley. It's a thing that's called Zachley. I'm trying to get it introduced as a medical term. It's called Zachley, where like if you don't clean out your teeth, that's when your mouth starts smelling exactly like your ass.
That's funny. It is true that we still talk about flossing as a prevention for periodontal disease, but flossing does not handle this. And again, if you want to get off the merry-go-round and you want to help a person, we do need to address several elements to create periodontal stability. This is the list that we use. These are the oral risk factors on the left and the systemic risk factors on the right. And right now we're talking about prediabetes and diabetes. If you want to be able to diagnose hyperglycemia or hyperinsulinemia, you're going to need to be able to do some A1C testing in your office, and it's really easy to do. Our periodontal disease brochure that we give to patients describes the complicated nature of this disease, some of the factors we look at, and then on the back, everything that's included in the perio package. It's personalized medicine, so it's everything as needed for that individual person. But you might be able to see on the back of that, it does say A1C finger stick testing. And we test all of our patients, all of our diabetic patients at the perio maintenance appointments as well. So this is the list of what we include. And if you move down about 3/4 of the way down, it says skill building series of visits, as many necessary prior to full mouth disinfection. Full mouth disinfection is what we call scaling and root planing, but it's also with ozone. There's other aspects of it, and it's with antimicrobial rinse and et cetera. And again, I can go into details on this, but we're here to talk a little bit more about diabetes, so I want to keep moving. If you want that brochure or any other of the course materials, here I have a whole big list of them. If you want to scan that QR code and download it, you will be able to get those course materials and be able to use them. I am not coveting anything. I want to share everything that I have. and I want to help you be successful. So diabetes detection and its relevance in dentistry, talked about the fact that it's bidirectional periodontal disease and diabetes. Diabetes is believed to promote the periodontal disease through an exaggerated inflammatory response to the periodontal microflora. We also know that evidence suggests that periodontal changes are the very first clinical manifestation of diabetes. When you see periodontal disease in the mouth, most of us don't think, oh, I wonder if they're now diabetic. We need to be better at that. If you saw this, a decubital ulcer, basically gangrene or a foot that's ready to be amputated, you certainly can see that this might be a diabetic response to a cut on the foot that the body is not tolerating. This is an exaggerated response to a bacterial invasion, but so is this. This is the mouth you saw earlier. And when you look at this situation, you think, what's going on here? This person's not high caries risk. Is there plaque here? No, this person's really good at plaque removal. And yet we have a lot of problems. I'm going to keep going here. Got into prevalence. We talked about fat chance, metabolical. Okay. Let me go back one. Oh, shoot. Did I get rid of my share? Shoot.
Yeah, it stopped sharing.
1 second. Let me go back a slide. All right.
It's back.
Uh-huh. All right. Continue to share. Rob Lustig wrote a book called Metabolical that I recommend, and it really is the lies and lures of processed food. And his first book, We Were All Influenced by Fat Chance, really just want to say you need to read this. It will help you get mad at the situation. And it is American to be mad at what's going on with our food supply and processed food and how it's impacted obesity and disease, including periodontal disease. The World Health Organization, I think I already mentioned that they want us to reduce our sugar consumption to 5% or about 2/3 of a can of sugar a day. This is Eric Clapton talking about the addiction level of sugar. Most of us know that sugar's addictive. I'll just play it.
I couldn't get through a day without doing something to alter my consciousness.
And it started with heroin
It
addiction.
started with sugar.
Sugar.
Oh yeah, when I was 5, 6 years old, I was cramming sugar down my throat as fast as I could get it down. Sweets, sugar on bread and butter. I became addicted to sugar because it changed the way I felt.
So that is real for people, and it's really difficult getting people to change their sugar habits and take a look at. Now we have lots of we have over the counter constant glucose monitors, CGMs, that are basically attached to the back of your arm, and they're communicated through your telephone. And this will be a game changer because this biofeedback really does help people realize when their blood sugar is getting high. The A1C level, let's talk about A1C. I love this, by the way, this advertisement, complete with your half gallon of soda for $2.99. KFC will donate $1 to the Juvenile Diabetes Research Foundation. Is that hilarious or what? We should be infuriated by this stuff. I'm going to keep going. We talked a little bit about fiber already. Here's the daily recommendations of fiber, again, to mitigate that hyperglycemia. You want at least 38 grams. If you're interested in weight loss, I would bump that up to 50 grams of fiber a day. You want to talk about being full and having appetite suppressants. If you try to get in 50 grams of fiber a day, you're literally not going to be hungry for the other foods that you're eating, and it will absolutely help you with everything. You want to look at fiber in the toilet. You want foot-long floaters, FLFs, light fluffy poops that don't smell. That's how you know you're getting good fiber, and plenty of water to go with that. And you won't have to worry about portion control. You'll be plenty full. That's about a basketball-sized portion of fruits and vegetables a day, 38 grams. And that means you need to store it in your refrigerator, not in the little compartments down below. I don't have time to tell this story about my son, but we can teach this to our kids. Here's the other problem with hyperglycemia is that we should be moving our bodies, and instead we're doing this. And we find lots of excuses to sit, as we're doing right now. And if you're eating during this presentation, great, but afterwards go out and take a 10-minute walk or put on a 10-minute core workout in your living room with no equipment. Do something. And when you have that glucose monitor on, you'll watch your blood sugar drop. It's important to try to keep moving through the day, not just hitting the gym, although it's super great to be able to exercise in a more focused time like that, as well as build nice, strong muscle and pull on bones and all of that. But this is the person whose mouth that was. She's the sister of my dental assistant. And when I saw her, I was at her sister's bar where they all hung out, and it was she's said, Susan, my teeth are drifting. They didn't used to have spaces between them. Can you help fix them? I know you do Invisalign. And I said, well, I can't do it today, but come to my office and we'll look at it. And we figured out that her A1C level was a 13. So we helped get glycemic control. She worked a lot on her lifestyle changes, and we were not successful at getting glycemic control with her level of periodontal disease. So these are the early type 2 diabetes symptoms: unusual thirst and frequent urination, but also bleeding gums. Bleeding gums have always been the first manifestation of type 2 diabetes. Again, we don't recognize it as such. Here are some other oral signs: gingivitis, periodontitis, dental caries, salivary dysfunction, reduced saliva flow, and of course, with that, you get fungal infections and other oral infections and taste interferences and neurosensory disorders. In Nanny's case, they put her on 4 different medications looking for glycemic control, and these were her radiographs 1 year later. She had even more bone loss. So we decided to extract her teeth to be able to help her live because we never were able to get her hyperglycemia under an A1C of 9.5, and then her insurance didn't cover the one medication, and it crept back up to 11. This is her with dentures. The day we delivered, there she is with her sister. She left. She's no longer an employee in the bar. She became a phlebotomist and then ended up going on to become an RN. It took her years. Look at this. Hey, soul sister, it's been a while. I just want to tell you I'm off my insulin as of February 7th. This was just last year. My A1C is 6.8 and only going down. Thank you for all you've done for me during my health journey. By the way, I was on insulin for 10 years. So I asked her what she did. She said, just my food intake. Instead of 2 tortillas, I ate 1, just cutting sugar and carbs out of my diet. She said, small step, big changes. She stopped drinking alcohol. She stopped drinking soda in her alcohol, stopped drinking soda. It was just one small change over time. And that's what happened. So with A1C, what are we looking at? We're looking at, instead of a fasting plasma glucose or oral glucose tolerance test, we're looking at a measure of 2 to 3 months average circulating blood sugar, 2 to 3 months average circulating blood sugar without fasting. So we can do this anytime we want. And it's nice because in the dental office, we can do a finger stick blood test and get the results within minutes. So when we look at A1C results, the evidence shows us that if there are 25% of the teeth have 5-millimeter pockets or 4 or more lost teeth, along with an A1C of 5.7 or greater, we can diagnose prediabetes or diabetes with 92% confidence. Now, we are not in the job of diagnosing diabetes. In fact, in our country, we're the only country that does not allow any point of care A1C machine to diagnose diabetes. I don't know why that is, because they are very accurate, but the A1C results in our country have to be done through a laboratory blood test. That doesn't mean that we can't use this as a screener and be able to write to their physician and say, look, they have active periodontal disease and whatever other risk factors you uncover, whether it's, let's say, Native American or Hispanic, those are risk factors, or I'll show you how to look at the risk, and overweightedness. And with all of the risk factors and the A1C, they can diagnose diabetes. So here's what the American Diabetes Association says about A1C testing. We want to test anyone who's over 45 years old, and if they're normal, repeat every 3 years. And adults who are overweight or obese and who have one or more additional risk factors, we would require testing also. So no one likes to be weighed in a dental office, so we're not measuring BMI. I did some research on how do we look at surrogate measures of overweightedness in our office, and I'll share those with you. But we test them right in our office. We use the DCA Advantage. There's also this Affinion. Both of these I think you can buy through Henry Schein or any of the medical or dental companies that you buy from. And we also can purchase these. This is a very inexpensive way to get into A1C testing. These are called A1C Now. They come with a pre-calibrated machine right in the box, and they're about 10 bucks a test. So in a box like this, 20, it might be $200. Maybe it's a little more now. And when you're finished with those 20, you dispense, you throw that machine away. Now, if you pull this out 2 or 3 years later, these pre-calibrated monitors aren't very good. So they do come in a box of 10. So I would recommend that you start there if you're just starting with A1C testing. I'm going to keep going. We developed through the research I did with Michigan State University and Department of Endocrinology and my office, we came up with a dental-friendly screening tool that looked at surrogate measures of overweightedness so we don't have to weigh people and figure out a BMI. And when we did that, we found out that we tested 500 of our patients, and about 100 of them were pre-diabetic or diabetic and didn't know it. So I've developed a health history. Again, that's in the materials that you may have scanned for. The health history that I developed has all kinds of conditions in boxes that's meant to be interactional to help patients understand what their risks are for various things. So again, I want to get patients engaged in curiosity about what's going on for them. And one of the ways we do it is through the health history. So I left some 5 screening questions on the health history, and then if they even have one yes answer, including bleeding gums, or then I switch over to what we call selfscreen.net, which is the screening tool. And again, you will have access to that. You can literally go on selfscreen.net, click on my name, and underneath me are all the people that have engaged in Total Health Academy. But you can just use my name, and then it'll open up the screening tools for you to take on yourself or even with your patients. And if you want to see the research study, there it was. And well, let's see. Oops, I'm going backwards. Hold on, sorry. Okay. There's the, no, I do want to go backwards. There are the screening tests. The surrogate measures of overweight are you more than 10% above ideal body weight, or is your waist above 35 inches for women and 40 for men? And then it goes on to family history. Are you African American, Alaskan, Native American, Indian, Hispanic, or Arabic descent? Do you have a history of take medication for hypertension? Do you take medications for high cholesterol? Or anyway, it goes on with some symptoms, and also has bleeding gums when you brush or floss, and then an age question. So those are great when you're communicating with physicians. Based on whatever results you get from the screener, you want to put those results in a letter with the A1C to their physician, or to make it easier, these paper tablets, you can just check off our Total Health Academy doctors have their name and logo down below, and you just basically check off the symptoms or the screening questions, and then enclose it in a letter with their A1C and let the physician know. These, by the way, these letters that we do for all kinds of things in our practice, let people know about what a total health dental practice looks like. Right now, today, about 51% of our new patients are referred to us by physicians. And you can ask any one of my team members, because those numbers are every month at our team meeting. We look at that. So how did that happen? It doesn't happen overnight. It happens a lot from writing letters of advocacy about your patients and letting people know what you're about in terms of oral disease and systemic risk factors. So I'm going to keep going. Oops, oh shoot, I wanted to, oh, I did it again. Hold on one second. Share. I want to keep going. Okay. When you're talking about addressing obesity with patients, it's sensitive, right? And a lot of people are like, I know I need to lose weight and I don't seem to be able to do it. These are the reasons that the dentist said that they weren't wanting to talk about it with patients. And one of them was this, by the way, when I say dentist, this was only a survey for dentists throughout the country. It was out of University of North Carolina, Jessica Lee's group, but it was a large segment of dentists that participated in this survey of whether they wanted to address diabetes. They said that they didn't want to appear judgmental. They didn't want to look like a hypocrite if they also struggled. They didn't have a strong interest. They lacked the knowledge and the education to do it. And I want to say, to be a friend to a patient means to hear their story. Facilitating health change behavior is a dialogue through which we support the patient's self-discovery. And that means that we don't direct them or educate them, that we can follow them, we can ask good questions, and we can listen. If you ask a patient, what are some areas of your health that you are concerned about or working at today at this point in your general overall health, many people will tell you they're interested in losing weight or getting blood sugar control. And you're basically able to just follow their lead and ask them, well, what have you tried and what has been successful and where have you stumbled and what are you thinking about next and what is your understanding of how you might be successful and where, what foods are your downfalls. I'm going to go past this video even though.
So they send them to regular doctor for a follow.
I just want to say everyone you meet is fighting a battle you know nothing about. So always be kind. I love that quote from Robin Williams. And I also want to say people hear what they're able to hear. So, they'll take it in small bits. The good news for us is that we're not physicians. We're not obligated to tell people in 7 minutes what they ought to do with their life. We can see them periodically and we can help measure their success. And instead of just following their daughter's soccer career, we can literally help them make better choices for themselves so that every single time they associate that dental visit with something we're doing to enhance their life to help them become the person they're supposed to become, the very best version of them. Remember when we use the word should or you ought to, or, we've done this a lot. We've should on people a lot in terms of flossing. It activates resistance for all of us. We want to avoid judgment as well, both criticism and rejection, and strong approval. Why don't we want to give strong approval? Let's say that somebody came in and they quit smoking and you're absolutely thrilled, or they just lost weight and you're just thrilled and you're going on about approving. You're really putting them in a precarious situation if they stumble and start smoking again, and next time they don't want to tell you about it, or they quit 3 days before because they don't want you to smell it, or you're in a position of being able to judge them. So you want to be happy for them. You want to ask questions like, how has this impacted your life? What difference has it made in you, your feeling about yourself and the people around you? And when they tell you themselves how excited they are, you can totally be happy for them. It's the difference between, when your child brings a picture to you that they painted, instead of saying, oh, here's what I like about it. I like this tree. I like this. You can say, what do you like about it? And how did you do this? And, we've learned to do that with our children, but we also want to do it with our patients. We want to ask powerful, open-ended questions. We want to be a really good story listener. When I say open-ended questions, it means that they're going to tell us a response, not a yes or no. This isn't binary questions like on the health history. It's very hard for us to get out of the habit of asking yes or no questions. We're very used to it. So getting in the habit of asking these questions and being willing to wait with them without judgment. Asking these 3 words, what is your story? Tell me more. I would love to know. This really honors people. And I'm really not having time for my story, but I want to just say in brief that I was born of 2 parents who smoked 2 packs a day each. I was born premature with bad lungs. I was spent 3 months in an oxygen tent. I had 7 hospitalizations for pneumonia under the age of 12. And I had 52 allergies, so my immune system was completely shot from all the antibiotics, etc. I was sick and overweight and tired. What we know about antibiotics is that they stimulate obesity. That's why we give 80% of our antibiotics in our country are fed to livestock, so we can support the livestock business and get their cattle um, uh, slaughtered more quickly. So I was a very, very sick child, and at the age of 13, I had a physician, an internist, who took on my case and saw me every week and helped me get to root cause through diet and exercise. And she is the reason that I'm here. And if I could tell you that I understood what she was doing at the time, I had no idea, but she wanted to hear my story, my struggle. And I had never had a chance to talk about what it was like to be a sick kid. I just tried to do what they told me to do. And I was over medicated, tired, couldn't pay. I mean, I could go on, but through helping me advocate for myself, I not only became a daily exerciser, which I was not able to do because of my lungs, but I started doing all the grocery shopping for my family on my bike and panniers. I got my parents to quit smoking. I turned my whole family around toward health, and the power of what children are able to do with a strong healthcare professional at your side is incredible. And I believe this is the future role of the hygienist. And I think it is a very exciting time in dentistry if we accept this challenge. So I'm going to talk a little bit more about reflux and then move to a close. This is a patient who came to me because she hated the color of her teeth. Her dentist made bleach trays, but the bleach just killed her teeth. And she's been going to the same dentist every 6 months. Again, I met her in a social situation. She said, I hate the color of my teeth, but I can't bleach them because they kill. Can you help? I said, please come to my office. What you're looking at there is teeth that have almost no enamel left on them. It's almost as if the veneer preps have been done. And if you look at the occlusal surfaces, same thing, and lingual surfaces, same thing. This is not bulimia. This is full-blown reflux and acid going down. She tells us that she's been to the dentist every 6 months and he's never mentioned erosion, and my team is mortified by that. She was taking Prilosec for, by the way, these proton pump inhibitors are awful. They rob your body's ability to absorb incredibly important nutrients like calcium, magnesium, and iron. Without those, you are not in good shape. And so the broad-based warnings on these proton pump inhibitors are that we should not be taking them for more than 2 weeks' time. And yet physicians put people on them for years. The minute she heard that these were bad for you, she switched to lemon water, which is very acidic. And when she wasn't drinking, to quell her reflux, because when you swallow lemon water, it does neutralize some of the acid in your stomach. Very interesting how it alkalinizes some of that. But it is not good to be sipping on. And when she wasn't drinking this, she was drinking Dasani, which is had a pH at the time of 3. Now, if you're looking at the pH scale, every time you step down in pH, it's 10 times more acidic. So a 7, which is where our body wants to live, anywhere between 7 and 8, going down to a 6 is 10 times more acidic. A 6 to a 5 is 100 times more acidic. A 5 to a 4 is 1,000. A 4 to a 3 is 10,000 times more acidic. Dasani, which is bottled by one of our soda pop companies, is every bit as acidic as the soda that we know, like Mountain Dew and Coke and Pepsi. These are very, very acidic. Where does enamel dissolve? At the pH of 5.5, and the dentin dissolves at a pH of 6.5. When I say it dissolves, we give up calcium from our teeth to buffer the acid in the surrounding area. And then we swallow it, and it's literally processed through our kidneys, gives us kidney stones. And we also take calcium, not just from our teeth to buffer the acidity, but from our bones. Because keep in mind, it's not just our mouths that deal with acidosis, but the rest of our bodies. So when we look at with our office, we use pH 2OH strips, and we're doing it a lot right now because we have a hydration challenge for our patients, and we're asking them not only to drink 64 ounces of water for adults, but to look at the acidity of their water. So that's kind of important. I'm going to go, these are the list of the proton pump inhibitors that we want you to avoid. We do know that if you go back one generation to the histamine 2 blockers, H2 histamine 2 blockers, it's a much safer drug for long-term use, although ultimately it would be nice to fix the diet to not have reflux. There are people that have hiatal hernias and other issues, but much of our reflux is coming because of the food that we're eating. So this is Jamie Kaufman's book. I'm going to go back one. Hold on. Oh no. Let me go back. One second. Here are the histamine 2 blockers. So H2RAs, Zantac, Pepsid, Tagamet, and Axit. Those are the drugs that we use before the proton pump inhibitors, and those are safer for long-term use. We talked already a little bit about carcinogenesis, but the proton pump inhibitors also create dysbiosis and infection, increased infection risk in the stomach. So when we shut down the acid bath that is in the stomach, which of course reduces the amount of acid we're irping upwards, 50% of the ingested bacteria survive by slipping past our gastric acid trap. So now we're starting to see some of the more dangerous periodontal pathogens living in the gut as well. And again, 70% of our immune system resides in the GI tract, so it's a critical line of defense. By altering the balance between good and bad microbes, the risk of systemic infection is increased. So again, when we look at silent reflux, we look at its impact in the mouth. I want to say that a tiny drop of stomach acid, even in the sinus cavity, producing mucus, and in the mouth producing, again, more caries and enamel risk. But take a look at what it does to occlusal surfaces when you have an acidic environment in the presence of bruxism. Now, instead of seeing, like little jagged edges, we're starting to see it looks almost like it's melting the teeth. And those are some of the clinical signs that you see. Also, we see a lot in the anterior, like this, where we see not only facial and lingual surfaces, but anterior bruxism. When I look at a patient like this, I see a lot. So let's look at it. The gingival tissue is red. It's as red as what's beyond the mucogingival junction, but there's no plaque. So I think either food sensitivity, nutrient deficiency, or acid. And then I look at the anterior bruxism. What do we know about anterior bruxism? Often we brux forward to what? Open the airway. And if this person had sleep apnea, we also know that when you stop breathing at night and then you gasp for breath, it puts negative pressure on the diaphragm and it sucks stomach acid right up through the esophagus into the mouth. So we often associate nighttime nocturnal reflux with sleep apnea. And we also don't want people eating right before bed, but they'll do it during apneic events. When you look beyond the mouth and look at the tongue here, you see a 2-ton gorilla trapped in a 1-ton cage, including the bars on the sides of the teeth where it's pressing up against the teeth. So all of this to me looks like an airway issue and reflux, but you'll often see erosion on the lingual surfaces. You'll see posterior teeth crowned. You'll see inflammation. And when you look at a classic case like this where there's lingual erosion, somebody might want to say, well, this looks like bulimia to me. It is truly nocturnal bruxism in the presence of acid. How do we know this? Again, this ledge right here represents a occlusal pattern, a deep overbite, where the mandible is literally trapped back. And what do we know about a deep overbite? It is one of the signs that we look at in terms of risk of airway disorders or obstructive sleep apnea. So that's that. But we see it, the thinning incisal edges on lots of airway patients. And when you look back here, this patient truly is a bulimic patient. There isn't a lot of, there's no gingival inflammation on this case. The enamel seems to be intact. And when you look at the lingual surfaces, they are eroded all the way to the gingiva. So this truly is the difference between nocturnal bruxism and airway. Now, this patient is missing bicuspids, and there's no question in my mind that if this patient doesn't have either upper airway resistance syndrome or obstructive sleep apnea, they will at some point. This is a bicuspid extraction retraction case, and we know that they're at risk, but this truly is a bulimic patient. I want to just flip through this really quick because there are lots of long-term acidity problems from acidosis, including osteoporosis, weak immune system, chronic digestive problems, arthritis, heart and circulatory problems, and cancers. When you look at cardiovascular disease and cancer as our number 1 and number 2 leading causes of death in our world, they are also on this list of acidosis. We live in an acid world. If you're interested in studying about that, just start looking at ChatGPT or anywhere on acidosis and cardiovascular disease, or go on Google Scholar, or go on any of the Open Evidence, which is the new AI source for, you just put in your dental license or even your hygiene license, and you can get on Open Evidence and start looking for the evidence for this in the literature. But we know a lot about acidosis and osteoporosis and kidney stones. And we also know that as we age, we become more acidic. If you could keep your skin, muscles, and organs and glands in an alkaline environment, you would dramatically slow down your aging process. So again, helping patients regain pH balance. How do we do it? Well, we want to hydrate, change what you're drinking, change what you're eating, avoid all ultra-processed food, including reducing acidic foods. What are the acidic foods? They're ultra-processed foods, proteins, grains, and when I look at this, and dairy. So when I look at this, it's things like cheeseburgers and chicken nuggets and cookies. Like, those are all very acidic foods. When you start to look at what the alkaline foods are, they're fruits and vegetables. The same thing we're looking at for phytonutrients and fiber. So again, we really do want to focus more on helping people enjoy a plethora of vegetables and fruits that they can taste and enjoy. With the patient that I talked about, she definitely had sleep apnea. We tested her for sleep apnea for all of our patients that have nocturnal bruxism and acid erosion. I would look at sleep apnea. And these were her signs. She had a deep overbite, scalloped tongue, worn dentition, forward bent head posture. How can I, by the way, how can I change the color of her teeth? Well, the only way to do it for her would be full mouth restoration. So I want to go through, I want to kind of get to that, see if I can get onto her. We helped her fix her diet and we restored her teeth. And while we were restoring her teeth, I had her on a CPAP. When we restored her teeth, opened her vertical, and gave her more tongue space, did some myofunctional therapy, and also fixed her diet, she lost 30 pounds, and the weight loss made a difference in the obstructive sleep apnea as well. She was able to get off her CPAP altogether and feel better. And you can tell by her eyes, not just her pretty teeth, but her eyes, that she is living a much better life. She quit her job as a she used to be answer the telephones for a big switchboard for a plumbing company, and now she owns her own yoga studio. So it's pretty cool. So that was that story. We kind of went through it pretty quickly. I want you to just look at her profile change in that picture too. But more than that, look at her eyes. Look how much happier she is. So once again, sick care or health care, you choose. Here's the close. Many people find that they want to put all these things together, but they don't know where to start. And I always say multitasking is simply a way to screw up more than one thing at a time. If you are at all interested in learning this one module at a time with your team, about a 3 to 5 year climb to develop a truly oral systemic practice, just like any health change we make, it's one step at a time, and you want to do it with the people you love. So it's a great way to get the entire team engaged. And if you're interested, you can take a look at Total Health Academy. If you don't like my teaching style, you won't like this because it's me teaching and it's the same sort of slide. So it's looking at all of this in more digestible bits. I will tell you that we rushed through a lot of this. I didn't know the level of sophistication of this particular audience today in terms of your advancement in oral systemic health, but I do applaud, act, and know that many of you are CE junkies and many of you got all of this today. So given that there's a big range, we probably do have a number of questions, and I'm happy to answer them. You can also look at totalhealthacademy.net. And I just want to end with be the change you want to see in the world. I think it's important for all of us to continue to try to walk the talk. And if you want to reach me personally with any comments about today or anything, other questions, Susan at drsusanmaples.com, or there's my cell phone number. Feel free to text me. And that is a wrap. And I know I'm over, so we don't have a lot of time for questions, but just
Awesome.
much in there. Sorry about that.
Fantastic presentation. Thank you so much. That was great. That was a lot of information.
I know. Sorry.
That was good. And now I want to check out this
So, we're going from
open.
Go ahead.
I love it. Thank you. You do have some questions in the chat, so I'm going to start there. First of all, a couple compliments. Excellent presentation. Thank you. A couple of people had to head out early, and they just wanted to make sure you knew that. And Christine wants to know, how can you suggest implementing the saliva testing, recommending labs, courses? How would she get started with that?
Well, that's a great question, Christine. Like, we use it for a lot of different things, saliva testing, not just for perio, but I probably would start there and do bacterial testing for periodontal pathogens. And when we do this, there's no way I'm going to do a perio case without knowing what bugs. To me, it's like, how would you show up and fight a gorilla with both hands tied behind your back? If I don't know what bugs I'm going for, how am I ever going to eradicate this? I'm not. So I think one of the ways that you could do it is to take a look at, I know a good way is, I think next weekend, come to Dallas for the American Academy for Oral and Systemic Health and hang out with all the people who originated all of this stuff, right? That's a really great group. And it's probably too late for you to think about getting on a plane to Dallas at the Cooper Clinic next weekend, but, yeah, it's the weekend after next. But one of the things you could do is become a member of AASH, American Academy of Oral and Systemic Health. And you can also reach out to me directly and I can give you some suggestions. I'm not one to want to share, like, there are a lot of people in the saliva world now, and they all have some space and place there. But I will tell you that we don't give patients an option. It would be like if you had cancer and the patient said, and I said to them, well, we need to run a few tests to find out how aggressive this cell type is so we know what chemotherapy to give. And the patient goes, how much is that, doc? No, I don't think I want that. I'll just pick a chemotherapy. Like, that's not an option for us. Like, if I'm going to try to tackle this, I need to know what we're doing and we also need to know how to measure our results, right? 6 weeks after no bleeding, however long that takes, we're going to measure, and I want to see a profile reflective of a future of health for you. I want to see that I've left you with a microbial profile predictive of periodontal health. Okay, same thing with A1C. We want that A1C predictive of long-term health. Next question.
Nocturnal bruxism photo. Can it be shown again?
Ooh, which one was that? Let's see.
And while you're looking for that, here's another question. Do you recommend starting with the child or adult total health pathway?
You know what? I think now I have it under a monthly membership where you don't need to start with either one. You can have, I recommend going through Total Health Academy as if you were showing up in a restaurant and you wanted to eat one bite at a time. If you're interested in a good infant oral health program, if you want to look at tethered tissues or pediatric airway, or if you want to start with any of the things we started today, I would get the introduction. I would do the first few where it talks about facilitating change, and then I would let me look back here,
And
and
then the one she wants to
then
see
I
is
would
the one
kind of
with the shelf.
Okay, yeah. So you see the difference where you see enamel intact at the first third of the tooth. This is a deep overbite where the lower incisors are right up against that. And there is acid present in their bruxing forward, but it's not from stomach acid pummeling the whole surface. So if I go to the next one, you can see the back is all the way down. Does that make sense? And you can also see the tissue is a little bit different there. Okay. I don't know how I got that red line on there.
Thank you.
Yeah, sure.
And you were kind of answering Doctor's question about starting with the child or adult, and you started giving the restaurant analogy.
Yeah. So if you were to, you can start anywhere you want in there. For instance, we do hands-on learning for every child at every visit. So what does that mean? It means a child comes in and we stain the plaque on their teeth and they choose whatever they want to clean their teeth. And in a mentored approach to self-care, the prophy is done by the child. And we're making sure they get every plaque surface done and we're helping them accomplish it. And then they're going home with some goals and we monitor behavior over time. Along with that self-experience, we do hands-on science at every visit. And so at the platinum level of THA, the learning lab of all the 80 different science experiences that they can choose from are sent to you. And it may take you 6 months for you guys to full on decide that you're going to convert your pediatric hygiene model to this before you'd want to go on to something else. Or let's say you want an infant oral health program, because we all should be seeing kids under the age of 1. But what do you do in that infant oral health program and how do you promote it? and how do you make it pertinent for both airway and caries reduction? And what do you do in an hour when you have all caregivers present and a little tiny baby who you're only going to be looking in their mouth for about 15 seconds? Like, what is it that we accomplish during that? Otherwise, all of these babies are going to the pediatric dentist and you're losing them for 16 years. So if you were to try to accomplish that, you got to come together as a team and say, here's all the elements. We have everything we need. How do we do it? How do we get the word out? How do we get it on our website? How do we promote it with social media? Maybe you'll do that. Or maybe you'll start with perio first, or maybe you'll start with reflux, or maybe you'll start with HPV oropharyngeal cancer and HPV screening, vaccination, those kinds of things. So there's a lot there. It's just eating it one bite at a time. And so I think it's all about the journey, not the destination. If you ever want to get on an airplane and come out and shadow my team for a day, you're welcome to do that. There's a fee to go with that, but you're welcome to do that. Some people like to see the whole package put together in one before they kind of see what it is there. It's, how to eat an elephant is one bite at a time, but sometimes you're eating the part you can't even wrap. Where does this go in the whole big scheme of things? So most people I find start with whatever is of interest to them. It might be a personal journey you're having, or a frustration or an area in dentistry you feel like, I don't know much about that and I really want to know. Maybe it's sleep and breathing for adults. Maybe it's pediatric airway. Maybe it's, lip and tongue ties, whatever it is you like. I think there's enough there that'll keep you busy for a long time.
If anybody else has questions, you can pop them in the chat. And that's also where I posted the link to get your CE letter as well. So you can write down the start and end code and click on that link to get your CE letter delivered to you. I have a question of curiosity. I know you told your story about when you were 13 and you had this influential provider in your life. So did you then, when you started your dental practice, did you know that that's the route that you wanted to go, or did you start this later in your career? Tell us a little bit about that.
Never would have been able to get, I never would have been able to get through the rigors of dentistry study without being well. So I was always grateful for that. I started out wanting to be a dentist, but I was bored. And 7 years later, I got an MBA and thought I'm going to leave dentistry. I bought a practice right out of school. So 25 years old, I was making a lot of money. I was really bored drilling and filling teeth. I didn't know much about advanced restorative dentistry. And I made a decision to sell my practice, but I was going to give it one more year, and I wanted to figure out how to fix my brother's TMJ problem, my dental assistant's TMJ problem. I went to hear Pete Dawson, and I sort of felt like I went to the mountain and Moses delivered the tablets, and I was like, on to another journey. So I bought in, but over time, I really was watching the decline in Americans' health. And in college, I went to Paris and I studied the European social medicine system. And I realized that their medicine system was really a mess, and ours was a mess too. And I wanted to be influential. I thought about going into policy change. I didn't know how to become. And then I decided, you know what, I'm just going to do this one person at a time and just try to help people be healthier. And when my son went to college, I knew I wanted a bigger speaking role, because I thought, if I can inspire you to help one person at a time, imagine what we could do together. But I know that I wouldn't be here today. I probably wouldn't be on the planet today if it weren't for that one healthcare professional who believed in me, who took me seriously, who let me fight my own battles, but encouraged me. Like, it was powerful. And I know what we're capable of, and it's more than we're doing. And I want so much to, I love everyone asks me at 65, what do you think about retirement? I'm like, are you kidding me? I'm finally getting the hang of it. No, I really do believe that my love for this comes from what I'm able to do in my practice every day, watch my team members, and then also what I'm able to watch through you, because all of my oral systemic friends are doing a lot of the same thing. And if it isn't us, who's going to do it? The last bastion of independence is only dentistry. And we're also the people that we associate prevention with. We are literally the last preventionists left. There aren't any others. So I think that we are worthy of this, and I think it's exciting. And you also earn the chance to do a shit ton of dentistry, which I love doing. You know, when people trust you and you're able to help them find solutions, you're attracting the kind of people who will spend their own discretionary money on dentistry beyond what their insurance allows. They're taking health into their own hands. Those are the kind of people that we find. Real quickly, I started about 12 years ago, a wellness and prevention study club. It's physicians in my area or healthcare professionals in my area that have values around prevention and wellness, not just around sickness. And we are 32 members now. We eat at my home once a month. I actually I bought a condo and converted my whole lower level to a giant dining room. So it's a learning center. So we eat at my home once a month. And um, my table only seats 18. So it's about 18 people. But we refer to each other. And a lot of our patients are well cared for within this network of professionals. I started a little wellness and prevention study club.com. If you want to look at the website, it's just for our patients to gain access. You can see what it looks like. But there's a module on building co-referral relationships in the collaborative and co-referral relationships in Total Health Academy. So you don't have to do it my way, but there are a lot of ways where you can build a group of people who you would want to see if you were sick. And also navigate the healthcare system. So if any of you had a question that you couldn't answer, we only have 4 minutes left, but had you asked 15 minutes ago and I couldn't answer it, I could have quick put out a group chat to my Wellness and Prevention Study Club. And right now, 10 minutes later, I'd be telling you what they said and or referring you, if you live in my community, to the person appropriate for you. I love the power of a village to take care of my patients and my family members, including my team members. And I think that together, if we're communicating, we learn to speak their language. We start to gain profound respect for the patient's role in their ability to help shape their future. And it becomes a complete privilege to take part in that transformation. So I'm sorry, I got really passionate there, but no other questions in the chat. I thought I'd take a minute.
Well, it's our pleasure to host you today. Thank you so much for spending your Friday with us and sharing your knowledge. So this has been fantastic. And many people are saying in the chat, thank you for the presentation. You've made such a difference in the lives of so many. Thank you. So yeah.
Thank you.
In
Maybe
case
I'll see you guys in Dallas in 2 weeks.
Yeah, there you go. All
right.
right. Happy Friday, everybody. Have a fantastic weekend and we'll see you soon.
Thank you, Angela. Thank you all.
Bye.
Bye-bye.
Thanks.
Bye.